you can probably see by my background, I'm not in the hospital. I'm zooming in from North Vancouver. And I also just want to acknowledge the original peoples of these lands and waters, specifically Tsleil-Waututh, Squamish, and Musqueam, on whose unceded ancestral lands are in the district of North Vancouver. And I truly value the opportunity to learn, share, and serve community on these lands in the beautiful Lynn Canyon area. And thank you to the CNSABC for inviting me to tell my story this evening, because I really feel like this is sort of my journey as a CNS, and really I'm just sharing my story and my experience. So before I get into it, I'll just expand a little bit on my role. So I've been a clinical nurse specialist with the Heart Rhythm program at St. Paul's since 2013. So prior to that, basically my background was in ICU and cardiac surgery ICU. So I was a graduate in Alberta when there was very few jobs. So I ended up traveling to the United States and working there, and met my husband, and we've been up in Vancouver for 20 years. So happy Thanksgiving to anyone else that has an American connection. So yeah, I've been at St. Paul's now for 20 years, and now with the Heart Rhythm program. So in the next 20 minutes or so, what I want to do is just go over just a little bit of the contemporary literature that I was able to find when I was researching this talk a couple months ago. And then I'm going to present 2 case studies from my practice. And hopefully in those case studies, it'll just sort of demonstrate how I was able to seek mentorship, or to share how I did that, enhancing research skills, how I became a mentor for nursing and some other allied health, how to identify some research-focused learning opportunities, and provide recommendations for other CNSs who may want to integrate more research and KT into their practice. So I think everyone here is quite familiar with the core competencies. Through our expertise with these 4 components of skill, our aim is really to improve patient outcomes. But as we all know, because CNS practice is very dynamic, the competencies and our role may change over time, over months, over years, and that's really based on changes in your program, any population health needs, any evolving practice changes. And I think, looking specifically at research and knowledge translation, what I've experienced is really this is the competency that's often the most challenging. And it really could be for a few reasons. It might be it's someone who's a new or a novice CNS, and maybe entry into their practice, they're just not really sure how to begin. They could have a different academic background. I think it may make a difference on what courses you've taken, whether you graduated doing a major paper or a thesis. And I think for others, it's resources and, maybe a gap in knowledge. And I think in many situations, we often gravitate to what we know best. And for some, research may not be something that they're comfortable participating in or leading. So I just wanted to touch on a little bit of the literature that I found. And there really was very little, but this particular study was looking at comparing over 3 different time periods. It was in the United States, and they were looking at research specifically. So what was the characteristics and their confidence and their motivators? And as I said, it was descriptive. It was over 3 years. And I think, the thing that I just want to highlight from this is that there was less than 42% of the CNSs that actually conduct research. And the rate really didn't change over time, whether they were, a new novice CNS or they had been practicing for over 5 years. So, I think what I liked about this was the recommendations that came out of this study, that, they felt that it was important to have access to mentors, to literature, to, encourage research activities, that it was important to have support and resources and educational opportunities, because, we're lifelong learners. So just because someone's been practicing or out of school for 10 years doesn't mean that, you don't want to have those educational opportunities to learn more about research. Another study that was really just from a few years ago was 3 Nordic countries. So this was Finland, Iceland, and Denmark. And what they were really doing was describing and comparing competencies among CNSs within those 3 countries. So For these particular countries, their competencies are 4 spheres that are kind of similar to ours. There's patient, which is related to evidence-informed methods to care for patients. They've got clinical nursing leadership, which is similar to ours. Organization, which is related to promoting best practices, innovation, and cooperation. Scholarship, which would be something similar to research. So, overall, what they found in this study was that organizational competency was the most frequency followed, but not surprising, the scholarship competency was the least utilized. So there was 39% that reported that they use it to a degree, to some degree, 53%, and 7% said not at all. The same author, actually from Finland, what they did was they undertook this project where they basically implemented, they implemented and then evaluated implementing a CNS role into one specific area. So it was one CNS, and they basically, this group led the design and implementation. And the activities in the competence building were based on and reflected their CNS competencies that they had in that particular country. So what they wanted to do was get a CNS into this role and evaluate it after 1 year. So for this particular project, it was someone who was a nurse manager previously. They were master's prepared. They had extensive experience in their specialty area. And again, we're building the role based on their competencies. And, as you can see from this pie chart, the clinical patient care was the one that was most utilized. So what they did was this CNS was they asked them to basically track their activity and their hourly work every week and then calculated it over the year. So their patient care was the most often was taking up their time, and not surprising was scholarship, with meaning research. I did find it interesting that only 7% was spent on education, because I do feel like that is, and with my experience and my colleagues, education is actually a large part of the role. But again, this was evaluated after 1 year, and I'm sure many people could attest to this, that after 1 year, you're really just getting your feet wet in a new role as a CNS. So I think it may not really be that fair of, an evaluation. And the last study that I found when I was researching this was really just this project, and this was in Canada. So it was in 2016, it was a partnership between hospital administrators and advanced practice nurses and an academic institution. And it was in Ontario and Alberta. So what they did was they partnered and they tried to create this program that would be like a research course, essentially. It was offered in person and online, and the content was adapted from different graduate level courses, and it was designed basically to help these people that were in the project to improve or increase their research knowledge. So there ended up being 20 participants between the two provinces, and what they found that they self-reported before they undertook the project and then after. And they did find that taking this course, which was online, it was in person, really enhanced their knowledge and their skills and their confidence in leading research. But I think, what I found valuable in reading this paper was their recommendations for practice. So basically, they said that it was really important for any organization to value that creative, that culture of inquiry, like the innovation, and put value on that. And also an organization that would prioritize research. They also, and of course, I'm sure all of us would love protected time to participate in research activities. I think for many of us, it's often done on a weekend, it's done off the side of our desk. And also having access to PhD prepared researchers and mentors is also very helpful. I call this a case study, but really this is just a project that it was is very dear to me, and really is morphed into research and mentoring opportunities. So it was the development of an ICD patient education session. So I won't go into the clinical details, but an ICD, or a defibrillator, it's a cardiac device that potentially if there's a potential lethal arrhythmia, the ICD can shock someone back into a normal rhythm. So in select patients, the ICD provides effective treatment for sudden cardiac arrest. But like any procedure, there's many risks, there's complications. But what's quite significant about a defibrillator being implanted is that there really are implications for lifestyle and jobs. And so at our site, and actually many sites across Canada, the conventional process or the pathway for when somebody needs a defibrillator will start with a referral to the electrophysiologist. So as a patient, you would come in and you would see the physician, and they would tell you that, you need an ICD, these are the risks, blah, blah, blah. You go home, and they'll say, my secretary, my administrator assistant will call and book you. So the patient would go home, and then basically they might have some written material. They're going to go to Google, but they don't necessarily have any more opportunity to talk to the physician or the nursing staff. And, anecdotally, we would have patients come in for an ICD implant, and they were commercial drivers, and they didn't know that they can never drive a commercial vehicle again. So whether that's from not absorbing the information that maybe they got, or, when you're sitting in a doctor's office, how nervous you can get. But either way, it was a gap in the education. And I often would think and compare this to when someone goes out to buy a car. So you go to a dealership and you look around and you have everybody swarming you, and you take a test drive, and then you go home and you want to think about it, and you have the salesperson phoning you and, hey, what are you thinking? And why don't you come back and take another drive? And I always thought it was just so interesting how you buy a car and you would come back multiple times to take a look and take another drive. But yet, you're being told that you need an ICD for, life saving, and yet you really don't have a whole lot of opportunity to speak to a healthcare provider to ask those questions. And so, from this, and also, from the literature, we knew that this was a gap, and how can we bridge this? So we wanted to develop some type of an education session. We wanted to have clinicians, but we also wanted to have patient partners. We wanted to have somebody, people who had a defibrillator implanted in the past that could share their experience. So the story of this was probably back in 2018. I developed a project proposal, distributed it to my team, the physician leadership, nursing leadership, and everybody was very supportive. So in building the team, you can see on the left are two expert clinicians. So Jamie is a nurse in the device clinic, and Emily is a device and electrophysiology technologist, and both of them are experts in their field. We developed a PowerPoint presentation, 45 minutes, and we really were trying to make it interactive. And the most important part of developing the curriculum and also our team was having patient partners. So we have 5 patient partners that have been joining us, and that yellow arrow points to Marcel, who's been with us since the beginning, actually. So once we had the curriculum set, it was just some logistics, like where are we going to do it in the hospital? How are we going to get patients referred? What time of the day are we going to have it? So we had our very first session in November of 2018. And I'm not sure Karen might know this story already, but this photo was taken from our very first session. And the thing that was sad but kind of funny now was this gentleman that's in the photo. He actually, we had nobody show up to our first session. So we saw him coming down the hallway where we were down in the basement of the Providence building, and he was actually looking for the bathroom, but we thought he was coming to the class. But when he saw what we were doing, he was interested to take a look at the devices. We had a few for him to look at, and we said, oh, can you just come in and we'll take a photo of us? And Emily likes to post everything on Twitter. And so this gentleman who was just looking for the bathroom actually came in, and we got a photo of him saying, oh, look, we started our first class, but actually nobody came. So it was very disappointing. I probably went home and shared a tear or two to my family, but it's definitely been fantastic since then. So Since then, we've had probably as of today over 200 participants, and we do the class every month. We usually have anywhere from 2 to 12 attendees plus their family. During COVID, we went to Zoom. We haven't gone back to in-person yet. We've still been doing it by Zoom. We go over, after every session, whether it's myself, Emily, and Jamie, we debrief. We talk to the patient partners to see what they thought, and then we also send out questionnaires to all of the people who've attended, just to get their their self-reported of what they understood about the class. And we made a lot of changes to the curriculum based on all of those evaluations and the team debriefing. And the thing that was really key was the patient partners. When we had the class in person, at the end of our 45 minutes, our hour, every person who was in that class waiting, referred for a defibrillator, would just beeline to our patient partner. And that's who they wanted to talk to. They didn't want to hear really from us about what we can tell them about getting a shock. They wanted to hear the story from the patient partner. And, we realized that they really were key to the success of this project. So, what we realized was that we kind of were onto something with, especially having patient partners, sharing their story, sharing their experiences. And so, from there, we ended up presenting our project at a few different conferences. We were able to get some money from the Patient Enhancement Fund at St. Paul's, and we were able to video it. And we have the recording now available on our website. And then just last year, we were really, really fortunate to have the development of the program published. So I think the important thing I just want to share about this experience is how, we didn't go into this as what can we do for research? This really was, a gap in care and trying to meet patient needs. And it just sort of morphed from there. So I think, if I could, give, my recommendations from our experiences, expanding your team. Like we just, we have, multidisciplinary team that we work with. And I think it's important to include everyone that you can, seeking mentorship and support, telling everybody, maybe that's through another nurse that you work with or someone from one of the academic institutions. It helps you bounce ideas off, and it helps to guide you in any kind of research or QI that you want to do from there. And I think knowing your limits and what is your scope is really important, especially as a new CNS, and a colleague or a physician says, oh, I would love to have you, take, why don't you do a quality of life or blah, blah, blah. And yet I think that you have to sort of, whether you have to go to somebody to, get some support or bounce ideas off, as I mentioned, I think it's just really important to know what your capacity is and what your limits are. And I think the other important thing is just sharing your story. So, we, kind of stumbled onto something was great for patients and realized that, the knowledge translation was the important piece, whether it's at a conference or colleagues that were in Alberta who were interested in how we were going about doing this type of education. The other study the case study was the development of patient satisfaction after atrial fibrillation ablation. So again, I won't bore you with the clinical stuff, but an ablation is a procedure using energy that will intentionally scar a part of the heart if somebody's got atrial fibrillation or atrial flutter. So it's generally a same-day discharge out of our hospital. They get a general anesthetic. And so about 2015, a physician that was head of the EP lab was starting to look at some of the outcomes after AF ablation and said, oh, I'd really like to look at patient satisfaction. Can you, help me do a survey? So, looking in the literature, we found this validated study. There wasn't a lot out there, but we found this one that was called the Patient Picker 15 questions. And it basically was looking at the 7 components of care for in a situation where you were in an ambulatory clinic. So, we wanted to see if people, after having the AF ablation, what their satisfaction was with the care that they received. So what we found was that 35% of them reported insufficient information about some of the danger signs on what to watch for when they went home. So, I went with my work, sort of the bread and butter of CNS work, that, improving discharge instructions through, we had we collaborated with the Cardiac Services BC for developing patient education material. We have discharge instructions, and, we made changes to those just to make the instructions more clear, when to go to the emergency room, when was it okay to call the clinic, and, understanding some of the potential complications that might happen. And so what happened from there was really growth in the project, because, from there, the physician that I'd worked with ended up publishing we published ours in a few different posters at a few different heart rhythm conferences, but the physician that I worked with went on to do a few studies looking at the outcomes after AF ablation, and using the patient satisfaction data that we had collected initially. And so, I kind of got myself onto that team, and it was really a great experience to then be part of that and sort of carve out something of my own. And I think, this project also then helped me to then go on and provide mentorship. So at our hospital, we have a research challenge that's offered yearly, and it's a fantastic opportunity for point of care, allied, and nursing staff to take on a research project. And so I mentored a team from the atrial fibrillation clinic, where, again, sort of morphing off of that AF ablation and same-day discharge, we wanted to pilot a project where we would have a nurse make a phone call on the day one and see if that helped any of the 30-day outcomes, but also seeing if patients were satisfied with that. So, that gave me an opportunity to mentor a team. We did present this data again at a conference in the spring. And then there was a student that was in the MHLP with me a couple years ago, who then went on to develop a YouTube video of the education that we now also have on our, we provide it to patients after their discharge, and it's also available on our website. So I think, what I would just say from this, particular situation, or this study, was that, sometimes it's just, you want to carve something out of your own. So, doing big data outcomes is not something that I have the capacity to do, but looking at quality of life, looking at patient satisfaction was something that is important and needs to be included. And that was something that I was able to, be part of with this larger sort of research machine. Knowing your limits, again, which I mentioned already, I think it's really important to engage collaboration and partnerships with everybody, whether it's, pharmacy or other physicians that you work with. I work with a lot of electrophysiology and device technologists, and everybody brings their own expertise. So, it's engaging with those people is just a key piece of our work. Seeking out opportunities for knowledge translation, different conferences, different poster venues, and sharing your research. I think it's important to network, share what you know, and it's always great to meet other colleagues, whether it's across Canada or in the United States, and see what other people do, and you can share what you do. Try not to, I say never say no, almost never, but when someone wants to collaborate with you, it's always just a great opportunity for you to meet and network and sort of branch out and do your work, create good work and work opportunities for yourself and for somebody else that you want to mentor. And I think, just going back to, the topic, or what I would say my takeaway message is, I think, as I mentioned, collaboration and partnerships are key, whether it's with like any members of the multidisciplinary team. It's important to share your ideas with the leadership. You want their support. You want them, you want your project ideas to be out there for other people to make suggestions, and also just for them to be aware and provide support to you. And I think, as a CNS, we're well positioned when we're doing projects like this, because, we can make sure that, certain studies are feasible, and are they effective? And, is this something that's in our scope to do? And I think we often are the ones that are able to identify like what resources do we have, and what can we have access to, and what type of a project is sustainable. And finally, just the dissemination of our findings. Again, these were projects that we identified from a gap in care, but we're able to find that the knowledge translation just built a bigger network of how we can share the great work that we were doing. And I think just to wrap up, I can't lie and say that I did this all by just looking for people to help me. I really have an amazing team that have been so fantastic, including me in research projects. And Dr. Mark DL, the EP team that I work with, are always encouraging and very supportive of the projects that I work on. And I'm sure many of you on the call know Sandra Locke, a photo of me and her, and that's probably from like 11 or 12 years ago, and I have a huge naive smile on my face. But Sandra has been really one of my biggest cheerleaders and one of my mentors, and supporting me in the work that I've done since I've been in this role, which I guess would be going on 10 years. So if everybody can go out there and find themselves a Sandra, it'd be fantastic. And that's all that I have. Thank you.
Well, thank you, Jackie. That's really great. It's amazing to hear how you just really engaged everybody along the way, how you had patients involved, even if you had to drag them off the hallway on their way to the bathroom. Kind of fun. But I liked that you really were able to conduct that in a very clear research approach and actually able to use that to drive forward patient care. So very cool.
Yeah, thank you. Thanks. And thank you again for the opportunity to share. Really, it's just, I mean, I'm sure most of you on here feel it. This being a CNS was just it's been the best job ever. I love it. I love the opportunities that I get, and I love sharing this with all of you. So thank you again.
Thank you for joining us. If you would like to learn more about our association, please visit our website at www.cnsabc.ca